Oh, good morning. Good evening there, Dr. Shirish and Dr. Prashant. Welcome
Hi,
from Mount Sinai for our Sun Pharma, this live case series from Mount Sinai Hospital. And I know you are from a very reputable center where we lost our Lata Didi ji, everybody talks about, Mangeshkar Hospital. And clearly, that whole world is mourning of her loss. But life, as we say, life goes on. And I'm sure there must be a big ripples there in the hospital that losing a giant and legend who made this and I'm very well aware of the hospital and then what the charity work it is doing in the Pune, because multiple trips I have taken to Pune. And here is on my left side is my associate who will be performing the procedure, Dr. Anpurna Kini. And then on the right side, we have fellows, Dr. Shiv Bagga and Ali. And of course, rest of the cath lab team. We are all ready to show something different. And I just want to make sure that you can see us, you can hear us well.
yes, we do.
Yes, we hear you.
And clear, loud and
Beautiful.
clear.
All right. So good. So we start our the case presentation. Unusual in the sense that now we are getting the patients coming with the structural heart disease. They have a mitral clip, they have a tower and TAVI, and so this is our disclosures. And both of you, Suresh and the Prashant, your individuals here. But know very well both of you, and Shirish particularly, head of cardiology at Dinanath Mangeshkar Hospital and very well versed with all complex interventions. And then, of course, I would call Prashant as a young budding cardiologist, interventionalist, making the name and doing excellent work. We are very thankful to our India, really very prominent in the interventional field. And we'll do this first case in next 45, 50 plus minutes. Then we'll have a case discussion for the IVUS in left main, which you have it, and then after we wrap it up, hopefully by 10, 15 or so. So this is our series number case 16. 78-year-old patient has a severe AS. Many times, of course, at that age, when they AS, they don't have angina. Everybody just had dyspnea. So patient has both aortic stenosis and then cath done at the time has a normal EF but revealed two vessel coronary artery disease. Many times we used to do cath beforehand, but this case cath was done on the table and patient have a sapien ultra valve and other factors are there and shows two vessel disease. Patient had a successful TAVI and now still has symptoms. We added amlodipine, but Anu can show now the angiogram in this particular case, which if we can show.
So this is just the access
Yeah.
we have. So you can see the sapien valve, left main and circ is non-obstructive. So you see some significant disease in the LAD.
There's a mid LED focal. I mean, little calcific, eccentric, but focal. But really tough one is this.
So just wanted to see, you see a lot of calcium in the ostium, which is telling us that there will be ostial RCA disease. And this is where it is. So it's anterior takeoff, subtotal, and shepherd's crook takeoff with calcium. So we know in this kind of case, guide is a challenging, and even doing procedure is very challenging because of the shepherd crook's takeoff. Majority of the calcium you see is in the ostium and also in the proximal part, just where the RCA curves down. Now the question always comes in this kind of vessel, what should be the guide of choice? So you see, when we do these cases, I'll tell you, let it play again. Anterior takeoff, you can always first try Lima guide. This is a Lima guide with side holes. When there's ostial disease, try to use a side hole so you don't keep seeing damping. The other one could be no torque guide also, which could be a good one in this kind of situation. So if you see here, it is just at the ostium, which means not completely engaged. So we should be ready to wire it. We are just at that level, this way. How are we going to wire this? What are the devices that we need to wire this? For this calcific as well as a subtotal vessel, I think first wire of choice should be a polymer jacketed wire. So our preference is always a fielder and always have over the wire catheter, whatever is your choice. So we always like a fine cross. So that is what we used, is a fielder fine cross, and I just have saved how to do this. Yeah, you want
Yeah,
to show it?
yeah. No, sure. But I mean, clearly, this case cannot go rotor wire directly because so difficult. Won't even make a first turn.
Yeah. So if
Yeah.
you see here, this is how you can see it. The fielder wire also not easy, gentle movements. And so what is happening is it has made two turns, a lot of calcium, wire is not going. So leave the wire there. Now you advance your fine cross slowly. So this is where again you'll have a issue when, since it is a upward takeoff, and see the guide is backing out. So what you do is again stop there, advance the guide. See the guide is coming back. Readjust your guide and then advance the fielder. So now the fielder is going. So what happens is, since it's a polymer jacketed hydrophilic wire, it's able to traverse the tortuosity very easy, like we showed here. I'm just letting it play again so you understand. See the guide is coming out. The the fine cross is just at the bend where we want it. So that's that fine balance we need to figure out, so that you push too hard, if your wire is moving and you have some resistance, you're advancing without, the guide will completely fly out. So you have to have that fine balance to understand. You have the guide, you have the fine cross, and just advance the fielder wire. So once this is done, you want the fielder all the way down, so you have a good wire purchase, and then you try to advance the
Fine cross.
fine cross now. So here we are trying to advance fine cross. So when you're doing fine cross, is same. With your right hand you're holding the wire, and with your left hand you're just torque turn corkscrew movement and just advancing with the left hand. Look at that, lot of resistance. Now the guide is coming out. As long as you know you're not advancing it too, so you stop at this point, again get the guide back in and get that. So now this is where we are. We stopped here. It's not going any further, no matter what we have done. Now, could we have used Corsair? Corsair has the fine braids and corkscrew movement, and movement of the fine Corsair is also good. Could have done that, but it's all up to which device that you are used to, and keep using the same device so you get better at it. So we like fine cross. This is where we are. Now we have to make a decision, is do we change to rotor wire at this level? Do we use another, fielder, the body is not the strongest, so do we change to another wire with a stronger body, thinking the fine cross will go down? Or instead of thinking the rotational atherectomy, do we think we should do laser? Because laser will go with the 014 wire that we crossed with. That's where we are.
All right, Dr. Shiresh, what would you do in this situation? We have tough time.
I think,
Fine cross doesn't go, it's kind of jammed there.
yeah, I think it's a difficult case to start with because of many things. Calcium is one, osteocalcium is another, tortuosity of the vessel. And so I think this was expected that fine cross may not go beyond a certain level. But I feel that this is enough. I would have just gone in with a rotor wire.
Okay,
I think
we are doing it now. Good.
Yeah.
So we take your advice, and we actually have the laser ready also. So laser is the one, I would say, when you cannot get this atherectomy wires, whether orbital or so, we know that IVL won't make a turn here. So, and this is, if need to be, we have the laser. The problem is that the wire of the rotor, although this one is...
Where we are? Some dies.
Still die? Yeah.
The vessel. Yes, a branch.
Yeah.
It's
in the branch. So you pull back the fine cross a little bit.
Yeah, but now we may lose everything.
Is it a extra support wire? Or
No, this is floppy. Yeah, because what happened is once you have the issues, you want to go rotor wire direct. So this is the new generation. the rotawire drive, the both floppy, and so in India they are not available yet, but they soon will
Not
be.
yet, but
Yeah,
it will come
but
next.
we are both Rotapro as well as this will be coming in India.
Yeah.
Yeah, good. Yep.
I think that's good enough.
Still will die.
Mhm.
Yeah.
Still in some branch or what?
No, I think we're okay.
Yeah, let's see.
Oh, yeah. It's going to every branch except the main vessel.
You want to use the clip? Many times I say use the clip as a torquer.
Mm.
Yeah. Yeah. No, we're still in the same different branch.
Yeah.
There.
Okay, get the clip.
Yeah. Right? Yeah. And again, you go with a very small. Once you have that difficulty, you have to go with very small bar. Smallest, which we know, is
I think we leave
1.25.
it there, SS.
Yeah. And the question is that if you can make a room for the proximal, your wire later on will move very easy. So we might just do based on this level that we have to pull back, I think, wire a little more. You are committed.
Mm.
Yeah.
If we pull back, we may not be
I
able
know.
to turn it more. Okay,
But
see
that's it. Then we just,
okay,
go.
I think we are in the main vessel now.
Yeah.
Yeah, that's enough.
yep, that's good. Okay. We
Now,
go.
same thing, you see the guide will be just at the ostium. So in this situation, we will be doing the burr right from the guide. From inside the guide, get into the ostium. Yeah.
We'll go very slowly. This is a very important point that wire cannot come back because this otherwise the rewiring is
I need the filter
tough.
to go back.
And this case, we'll use a pacemaker in case patient develop bradycardia asystole, which is not uncommon with such a calcific lesion at the ostium. Okay, you want to pull slowly?
Hold on. Normally you don't need two people, but here what is happening is you can curl around here, make circles, but since this is such a complex wiring, we just kept everything straight.
Okay.
So
Yeah, now
this kind of case, you have to go with the smallest burr, so it will be 1.25 burr. And after that we can decide, do we change the burr or we can just
means upgrade the bar also.
acronym, yeah.
Okay, let's go to the slide presentation so I can finish the presentation and then we'll go back to it. Okay, so this is our plan today. Complex PCI of the calcific RCA and LED we might have to do some other time, and maybe with a small bar we may have to use IVL and the drug-eluting stent, but have to do rotational atherectomy first. Now, there are clear guidelines for tower or structural cases and stable CAD by OC 2017.
speed.
So basically, is proximal LED, you don't need a functional testing majority of the time. So this is the case, one drug, so it is appropriate. Why? Because this feature, wait one second, this feature is very debatable. This association of the tower and CAD. Because there are one trial, then activation trial, some data have come that when you have a severe AS and CAD, you do AS TAVI or TAVI alone, because if you do a PCI, they have more complications. Some data said yes, little better with the cell TAVI. But we have one randomized trial, activation trial where 1 year outcome only, about 240 patients, PCI or medical therapy. So PCI and medical therapy, no difference at 1 year. Later we do not know, but then there is much higher bleeding in the PCI group. So PCI failed in this particular case, that randomization of the CAD. Now, major trial is the complete tower. Just like those investigators did a complete trial for the STEMI, culprit versus full revascularization, the same thing they are saying, complete revascularization or medical therapy after putting a sapien valve. So we are actually part of it. This we just got ready. We require IRB time and follow-up will be 3 years. So we will be doing these kind of cases, sapien valve, and then once you are satisfactory, hemodynamics are good, then you do the PCI, whether same time or later. So this is where very important trial, but it will take at least 5 years for the data to come, complete revascularization versus medical therapy. And then engaging the coronary is much difficult. We have published, and now Anu has made a special tower cathode to basically how to engage app.
Yeah.
In the app, a special app has been made for this. You know that with The sapien is less trouble, but definitely it's a much more trouble, particularly with the self-expanding valve. So, but anyway, with that note, let's go and try to get to this complex case. Ready?
Okay.
It is a 1.25 bar. It's a rota floppy drive.
Okay, I'm just gradually advancing, and Dr. Sharma is just holding the wire. So both have to be synchronized. So if I advance fast, the guide will come out. If he actually is, pulling the wire faster, the wire will come out. So it just have to be synchronized movement between the two operators. We can show the hemo also. Good. Now, also what I'm predicting is as you're coming closer, the burr may not make the turn here. Guide may come out. If that's the case, we will start burr, yeah, right there. So you see that we are not going to even plan to go inside the vessel. Leave it there. Do your 3 steps right here and start burring from the guide. So your 3 steps, movement of the knob, backward, forward, all the tension from the Teflon sheath and the rotor burr is gone. Then here, between the bar and the wire, Y connector, remove the Y, press it, move
Yep.
backward, forward, that's done. And last on the Dyna glide, you're on Dyna, if you see here, and then I'll just press it on fluoro, press,
Good.
so no movement.
And it's
No
a
jump.
150,000 RPM usually.
Yeah.
Good. So we are ready to start. Your guide is outside the ostium, as you can see.
So now my left hand is holding the guide. If you can
Yep.
show my left hand, and then I will start the flow. Actually, yes, I don't know whether we have to make the turn. The majority of the calcium
It's just
before.
vertical. Yeah,
yeah.
that's fine.
So,
Yeah. Okay. Now 1 second. See the hemodynamics. Pressure is down. Pulse is low. Give atropine and give a neo. So never do rota when systolic pressure is in double digits. Has to be above 100. But that is part of the bradycardia which is created. So now we are going not. I don't want to pace it unnecessary. The necessary pacemaker is there at a backup rate of 50. But we are giving atropine. We are giving neosynephrine, which is 100 microgram. I know some people use dopamine, anything to just increase the pressure.
Little atropine, okay?
Yeah.
100 mics only.
No, 0.6 atropine
6.6.
and 100 of the neo. Good.
We stop there, right?
Yeah.
I want to make a turn. Okay.
Good. Did. Sene.
Fluoro save.
Good. Okay.
So it was, you see that?
Good.
Gentle. Not advance or push. So it comes out. But only enough. I think we should be able to balloon now.
Yep.
Hand me the fielder wire.
So always comes. I tell people, doesn't matter what size burr you use, try to put a wire side by side if possible and use your balloon. And if you have expanded, you are done. Even with a 1.25 burr in a 3.5 millimeter vessel. And nowadays, if you're not, you can always use the IVL. I know IVL cost always has been issue, but that's another device which we have now to make our life, little interventionist life, much easier. And that actually use has become quite tremendous in United States about the IVL now. Even there, we take the picture to see how things are. Sine?
I want to see if the guide is there.
That's okay.
Good.
Good. Okay, we gave a very small amount of dye. Yes. So far, so good, which we call.
What balloon we have?
We have compliant right now.
3O.
2.5. Then we take a 3O20 non-compliant. This is 2.520. Go,
Actually, it is
go,
not
go,
going
go.
to go.
No, I know. But right now, yes. Because then we take a 3O20 high pressure.
It's not making a turn.
Or 3.5 even, second one.
I think we need a 12 balloon.
Okay, so 3.5 or 3O12?
3O12, right?
Okay, 3O12 we can take. Yeah. Take a backhand, give it to me. Okay, any other comment and ask our audience to the questions.
Couple of questions.
Yep.
So, a couple of questions. What is your workhorse burr size? Is it 1.25, 1.5?
No, 1.5. Workhorse burr size is
1.5.
1.5. Yeah.
So,
So if we
when do
use,
you
let's say 100K, we do about 60 rotation atherectomies per month. So if we take 100, so our 70 will be 1.5. About 10, 15 will be 1.25. And then the second will be 1.7, like 20. And rarely other bigger. Now that number bigger burr now almost has disappeared beyond 2.0
Yeah.
since the IVL came.
And what is your standard speed?
Yeah, same 150. You know the new Rota Pro which will come. I designed it. It comes with a fixed 150. You can increase or decrease what you want, but majority of the time is 150 is the one will be there. Yeah, we know that ablation efficiency is slightly less, but tolerated better.
Yeah.
We published long time ago. Less CK release, less chest pain, slight lesser perforation, and therefore this is what we suggest. Go.
Remove the connection there.
Remove it, yeah. Okay, yeah. So key is that 150, 155. So we saw that. We went with a 150. One time went down to 145 usual, which is 5 to 10,000 drop is okay. But then one time it became, went down to 135. Yeah, just when it went to the angle. Okay, now this is a 2020 compliant balloon. Let's see if we makes it. Usually I don't use with a compliant. This is already 2.520 compliant, and then we'll go to the high pressure, so 3.012 or 3.512. But compliant just because we knew that we are doing a suboptimal burring. Otherwise, would have gone with the extra bigger, non-compliant. So this is. Let's come to the ostium, and then we have a 3.012. And then you can combine here cutting balloons. So question is, do you use IVL or so? I would say that IVL in this situation will be more additive cost-wise, with no matter which part of the globe you are, and you only use it if it requires that your lesion didn't open.
I think we can just do high pressure balloon.
Yeah. Yep.
You have 3.5? 3.5.
3.520?
Yeah.
Yeah, 3.520.
High pressure.
Yep, yeah. Non-compliant, yeah. So, and then key is that, this whole issue, I know that we do a lot of TAVI at ESCC, probably does the highest. In next 2 days, I have 5 TAVI scheduled. There is still a lot of people with a CAD. They want me to do PCIs. And I can tell you, our threshold is very high to doing PCI in America with the TAVI patients. And particularly, some data showed that doing a concomitant PCI in these patients may be even harmful. But complete tower trial will answer that question. But I'm sure you are aware that everyone, if there is a disease angiogram, they all want us to put a stent.
Okay, one more question. Can
Yeah.
IVL be used for osteal lesion like this?
Yeah,
If
so
required?
that's a good point. So the question is that whether IVL would be doing now. Okay.
Oh.
Yep. So IVL definitely. So the whole question comes that if it's coming into the contact partially will be outside. Can you use an osteal lesion? Some data are coming, although that osteal lesion in the original disrupt CAD trial 3 was with like exclusion. But in routine life, we are using it. Yes. What I would not use in the osteal lesion is orbital atherectomy. Because remember, orbital, it runs because of the burr, and otherwise it will just, and we actually had,
3.24. Thomas.
when we had synergy or Pomus, okay. So when we did orbital of the osteal left mains, when it just came, and we had a few dissection of the osteal, although some people have used it, but we tried not to. Yeah,
this is one we need to document here, that the ostium is actually well taken care, expanded, which it looks that way. If not, then this is the time we have to make a decision. What's the next step? Whether to atherotomy with a cutting balloon
or use IVL if it doesn't expand. Yeah, let's take a picture. So we'll see.
So you would use, sorry.
So you see that what I did, I advanced the guide with the balloon. Normally we tell that do not advance when you have a balloon, deflated balloon. There's a risk of dissection. But in osteal lesion, which is osteal right, osteal left main, you can do that gentle.
Good.
Okay, so then
Very 24.
24, right?
Yeah.
3.5? Yeah.
3.5, 24.
And
so,
then get us a 408 high pressure for the osteum.
And we have the IVAS also ready. to show in the
Don't
end.
make that turn.
Huh?
Leave it.
Yes,
Can.
ostium, particularly ostium. So key is here. Just very important points that don't be fixated that until you know what it is. So you have now expanded here. So don't need anything further. In the sense, you don't need any cutting balloon. You don't need any IVL at this time.
Do you think mid RCA also has calcific lesion, which is
Yeah.
significant?
Yeah. Well, I mean, we actually we saw it in other view. It definitely is moderate lesion. Proximal now, after opening the proximal, it looking a little more significant, and every time the wire was going in different direction. And we'll see if we really feel in other view also tight, we can definitely take care of it. But in this particular case, from our American point of view, we'll try to bring this patient back for the LED after a few months. I'll not do the LED at the
X-ray
same time.
disabled.
Huh?
Disabled X-ray. Somebody pressed.
Yeah. Okay. Now this we have a Promus Elite 3.520 24.
That may be too long.
So here, whether you need a guideliner Godzilla or it will just go by itself, just need to see. Remember, we have one wire already there. Our rotor wire is there. Then this is the fielder.
Or we go with the shorter.
No. That take a Godzilla. Take the rotor wire out and Godzilla. Try again.
Yeah, it's not going to go. Not
Yeah.
the wire.
Right? It went in probably.
No.
Yeah. So I think it has to go inside. Yeah. So good wire purchase, as you can see, kidney doing and moving it. The guide catheter trying to bring more aligned.
No.
Good.
So we
I
lost
think it did. Right?
No, it's too much. It's
Huh?
at least 4 millimeters sticking out. That's why I said maybe go
Okay.
shorter.
So what do you want to do? Take the rotor wire out. Rotor wire is done right now.
Yeah, see, it's not. You want to go 20 maybe?
You want to 20? You want synergy or no?
No, I want to
Huh?
It's not good for the osteum.
Okay, tell us what you want to do now. I would say use the guide liner.
Guideliner, yeah.
Yeah.
Godzilla.
There's nothing wrong in that. Guide liner, Godzilla. So any other questions
Sharma,
there? Yeah.
Yeah, you chose to keep the rota wire.
Yeah.
Was it because you wanted a buddy wire effect or a
Yeah,
cutting,
exactly.
balloon effect?
Yeah, that was the reason. Yes.
Extra
So and yeah, extra support, and of course we take out when at the time before deployment, bring the balloon first. So yeah, 3.5 is okay. Or the 2.5. Yeah, the
Also, you
2.5.
have
20.
chosen,
Get us a new
you
12
have chosen the
balloons. 12,
Promus
3 or 12,
platform
right?
over the Synergy.
Right.
is it? What
Yeah,
is it?
Promus or Synergy. Now, my only question is the Synergy at the ostium. Synergy is a great stent, but because of extremely thin wire, I mean struts. So ostium, many times we see in the calcific lesion, although Synergy is made by Boston Scientific, which makes the rotation atherectomy for calcific, but we have seen that ostium, it doesn't perform as well. So we will, in the ostial lesion, preferably, our algorithm in our lab is here, either go with the Promus or go with the Zions. So this case could have been the Zions also. It's a Zions or Promus. Now, I personally think the Zions probably more deliverable. Orsiro is another choice, which is very commonly used. And now we just have the 3-year data of the Orsiro bioflow. 4.
But
Good. Good, that's fine.
Orsiro
Don't
has
go further.
good
Why are you going?
Yeah, it won't go. I'm telling you.
Do it for the, okay. Yep.
Do you think the strut thickness makes a difference in calcific osteal lesions?
Yeah, definitely. Yes. So, I mean, point is there is so much elastic strength.
Okay, go now.
Huh?
Deflate. Wait.
Tell us what you want to do.
Okay, 1 second.
Do I go a little more with the balloon?
No, stop. Deflate. Because it's a 3.0. It's coming out.
Mm-hmm.
They're a 3.5.
That's fine. Let's go up a little high pressure here.
Then you'll dissect it. Careful. Okay, now go up.
Okay. So same. You want to anchor your balloon. Not very high pressure if you are not going to stand that area.
Yeah.
Good. And then you deflate. At that time, your Godzilla will go down. Yep. Very good. Good. Fine. You see that technique? Basically, further down, we anchored it, then deflate. That is the time when we had our ACC live about in 2016. We made the point on that very calcific, tortuous RCA, the whole steps of advancing these uh, guide extension catheters.
The wire has come back. Try not to advance the wire right now because the Godzilla will come out. So now go with the. So
We
very
see.
important that Godzilla had to make that first turn.
Yeah.
Yes.
That is, for that you need the balloon way distal. But there you saw that it is angiographically non-obstructive. So you have to be very cautious that when you're deflating and inflating the balloon, we are not causing a balloon injury dissection of the, RCA further down. Okay, now we are good. So we know we are across. Always go with the stent distal to where you're going to deploy. And now we are ready. I'm going to just get the Godzilla out. I'll advance the guide, have it ready where we think we want to be. Then I'll get the Godzilla out. I think this is where we want to be. Some die.
Sine.
No, die. So we know. Yeah.
You have to pull back even 1 millimeter, but that's okay. Yeah.
Yeah.
Go.
Okay.
Ready?
Want to pull back a little bit?
No, that's fine.
I think so. We are good. Okay, go up.
Going up. So we'll go to
And
16
get,
atmosphere.
yeah, and then get us at 4.0, high pressure. So we're already going 16 atmospheres down. 408, right? Yeah. And then we'll do the IVAS for the ostium. Any questions on the steps that we shown so far?
No, I was a little worried about the balloon itself when you inflated balloon, and you said that you did it at a low pressure, but
Low pressure, yeah.
It will still injure the vessel. So
Yeah.
would you
No,
have to
usually
cover
what we
that?
should, usually what we should do is 1-to-1 balloon size. So we probably needed a 3.5. So first time you see that, balloon came back. It was with the low
Yeah.
pressure, but balloon came back. So always you have to make sure you're distal and 1-to-1. 1-to-1, about 4-6 atmosphere, hopefully no injury. So now see the guide went in, that's okay.
Which is good.
So it is essentially saying that that particular area that was significantly stenosed, now the guide is going in and you don't see any damping at that level. I mean, I know we have sidos, but that the ostium is covered.
And which is the best view to look at the RCA ostium? When you're
LAO,
placing your stent?
yeah. I think LAO, otherwise caudal. You go LAO caudal. That's the time also
LAO.
you can see the nice ostial. It's very important. I always teach my fellows here that you got to know how to nail the ostium. Ostial RCA, ostial LAD, ostial circumflex, as well as ostial left main. Very, very important. Ostial left main is cranial, whether it is AP, RAO, LAO. Here, straight LAO was showing us. If not, we would have gone little caudal. Once we are placing the balloon and dilating it, I'm going to go caudal and tell you what is the view that we like to use.
Dr. Sharma and Dr. Kini, your backup plan was the laser if you couldn't advance a rota wire.
Right, that is correct, yes.
So, we have easier access to rota and to IVL. Would a backup plan for us, someone who doesn't have laser, be using a small balloon to make way for an IVL and then use the IVL in such a lesion?
Okay, going up.
Yeah, I think that would have been a better.
But I can tell you, having done those now, quite a good number of IVL cases. IVL even, because what happened is, even when fine cross didn't go further down, so much resistance.
Yeah.
So we might have done with a little balloon would not have opened this calcific lesion. So what it did is 1.25 bar, just cut the interelastic lamina. But yes, if you can get a good reasonable lumen with a 2 or 2.5 expanded IVL. So I'm here very much, if I had to bet, that whether IVL will go in this case is unlikely. Even if you open the balloon, the area with the 2 or 2.5, whether it would have gone even balloon would have gone is the issue. But yes, if there is no other choice, if the rotawire does not go, then you have to go with the balloon, little open lumen, then go with IVL.
Yeah, if
Yeah.
that's the case, and if IVL does not go, just keep ballooning it.
Yeah.
So
If balloon
many
goes,
people,
if balloon goes.
No,
Yeah.
means small
Yeah.
balloon would
Yeah.
go.
Yeah.
Now, I'm showing you the ostium here. I think it's clear
Sinne.
to people, right?
Sinne, this
That you
one
can
now,
see
yeah.
it. And the other thing is, I'm probably the only person that use the shutters. You see here? That's where the ostium, that you can see very well. Is the ostium covered or no? It looks very good.
Yeah.
Shutters is a good way. We say poor man's IVUS
Good.
to see.
Stent boost.
Or the stent boost. Yeah,
Yeah,
only
stent
problem
boost.
with the
Yeah, we
stent
call it
boost, the
stent boost.
radiation. Yeah.
Radiation.
Yeah.
I rarely use stent boost.
But the new stent boost are part of the same your angio,
But
so it
still,
does not
still-
increase the radiation, or not that
Still
much.
have-
But old stent boosts are very increase the.
No. We are talking stent boost for you to see the stent. I'm talking about for you to place the stent. When we
Yeah.
are placing the stent, which view do we go and how we make sure we can see it very well. And that's when I'm saying use shutters, so you know it's a smaller area. Concentration of the radiation is in that small area. You're able to see it better.
Okay, so let's take a picture now. See where we are.
Okay, good.
Ready?
Yeah, I'm just caudal view.
Yeah.
Okay. I'm just getting it just at outside. Everybody happy? It is well covered. Ostium.
Yeah.
Yeah. It looks
Question is the mid lesion. Now only question remains the mid lesion now.
Yes.
Yeah.
It does look sinister.
But then it's a further down also. It's a long segment.
I would leave everything alone. This guy was
Okay,
like
good.
asymptomatic finding.
Yeah. Yeah, I think let's do the IVUS for the proximal. You want to take this for now?
This is probably irritation by the
Yeah.
wire.
Yeah,
Go
yeah.
back to our original picture.
No, there was moderate lesion all the
Moderate, I
time.
know.
Yeah.
So
Yeah.
the wire has.
No, but
just
now
made
we are in the
worse.
caudal view. It's a different view.
Okay.
Maybe
go
just
to the
showing it.
original Pictures.
Yeah. Yeah.
No, next one.
We never had a good, see there, moderate. But remember that was moderate. Let's say if this would have been the only lesion, we probably would not have brought this patient back. So that way, let's see that if we can just come about it. We are good. Let's do the IVUS and we complete, and then we'll look into that aspect when he comes back for the LED. We'll bring him back stage.
Okay, see this?
Good. Yeah.
Alright,
See, even the
okay,
IVUS is
that's
not going with the first turn.
I told you that.
Good. That's
Okay,
fine.
leave it. Just the
Yeah.
ostium.
Okay.
Do you see it?
No.
No, I know, but we are not.
Yeah.
This
Good.
is just ostium.
Yeah.
Yeah, pull back. You will not have a lot, maybe few millimeters.
Yeah.
Scanning. Stent is
Well, opposed.
very XO.
And 1 millimeter
Okay.
outside,
Yeah.
1 or 2 cells. Good.
So now
So I think we are done.
I'll check again.
So key is, in this particular case, take everything out. We take a last picture. Yeah. So what we are going to do, we are going to bring it back. As we said, take the pacemaker out. And take a last picture. The low mag, we always say, complex case, low magnification. So you see the distal vessel without moving the camera, and just to rule out any wire perforations and so.
Why did you put on this side?
Good.
This,
So,
this here.
Dr.
Why?
Kinney, Dr. Kinney, you demonstrated how to use the
I see.
fine cross microcatheter with the left
Yeah.
hand.
Yeah.
Do you routinely use the rotatory movement for the fine cross, or you restrict
Yeah.
it for the corsair? Which one?
Sinai.
Both.
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 Both would you like?
Yeah.
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 Yep. No, rotatory, and again,
Advancing means suppose now you are using fine cross like LED. If you see LED, we showed the LED,
Sinai.
and it is tight lesion, and if I'm allowing my fellow to, looks good.
Good. Very good. Yeah.
If I'm allowing my fellow to do, which we are, I mean, our institution, most cases, 90% fellows are the primary operator. They do all the cases, so we are just in the side when they're doing it. But we will not allow that LED to be wired, direct wire, because there are multiple branches. There, fine cross, you don't need to do rotatory movement. It is just you're using to cross the lesion. Here, you have to use rotatory movement because it is more than 90% and tortuous vessel. So you need some rotatory movement, and like I mentioned, backward, forward a little bit, and you're just going forward. I mean, you know how to definitely use it with the Corsair. Same thing, even with the fine cross. You just have to be very careful also that you don't keep rotating on one side. Sometimes you have to, undo it also clockwise, anti-clockwise. Otherwise, you will create mm, uh, just
Break.
even the catheter can break, and all these things have been seen. But yes, uh, clockwise, anti-clockwise movement is very important for this catheters to go forward, and also that movement will be atraumatic. That's the key, that you're causing atraumatic movement of this catheters. And why it's important, this kind of cases, also when you're doing CTOs, that you cross the wire, and yeah, and then you want to get your this catheter across, then you have to know how to get the catheter across, especially in CTO wires. What are you saying?
So actually, the proximal edge is not covered also.
On one
That's good.
side, yeah.
Yeah.
So key is that other thing which rotation, I always say, like roughly you don't have to really count it like 12, 14, but don't keep doing it, because we have seen tip separation of the turnpike, the fine cross rarely, of the Corsair.
More
If you
turnpike.
Yeah, turnpike is we have seen many of the turnpike when you keep rotating. So question is, you do 12 to 14 and then undo it for 4, 6 and then redo it again. So keep not spinning, because what will happen? That this is jammed in that area and now you keep rotating. So with this jam and rest of the one will just snip off it. So with that note, if everybody is happy.
Any other questions?
Yeah.
Wait, any
No,
other
Any
yes,
questions?
Yes,
Yeah.
Several questions here, and
Yeah,
most
sure.
of them are pertaining to your choice of a stent, particularly when you have calcific lesion. Most of them are, the newer stents, the thin strut stents are more deliverable. This was a combination of both a very difficult to deliver stent lesion, but at the same time a calcified lesion at the ostium. So the questions are primarily related to, would you use a thin strut stent in such cases? And the other is, you say your choice of do you routinely use an OPN balloon for such cases? So those
Available, but you are right. In this particular case, after the first balloon, we can use opium is a double layer balloon, which is not available in USA yet. But yes, opium balloon is before going to the cutting balloon, if you need to, you use that. And the stents choice, I'll ask Anu to comment on it. Thin strut, 60 micron,
Ultra thin.
more than ultra thin, or thinner about, which is 72 to 80 micron.
No, I just want to tell you, I mean, majority of this data that shows that this, yeah, we know that they're very deliverable, the ultra thin strand, all these things. But these kind of calcific lesions are not part of the trial. Osteal lesions excluded, heavy calcium is excluded from the trial. So we don't know what do they show. Our own data, we have seen in heavily calcified lesions that this particular stent that we use, because the strut is still about 75-80 micron thickness, does very well in the ostium. So
And so also the Zymes. I would say the
also
Promus
Zymes.
and Zymes, both will be very good in this situation.
yeah, so these two stents
So
have
for
done
the-
very well. So based on our experience, we keep using it. So unless we have to use the ultra thin stent on this heavily calcific lesion, and we need outcome, because we have a database ourselves, ACC NCDR, and we report also to the New York State. So all this, we know our patients are followed up to 1 year. And we have data in these cases. So these stents are doing very well. So we didn't want to change the practice.
Yep. Now, Shiresh,
So
you
for
have
the
some question? Yeah.
No, yeah, for the osteal lesions, you're almost going for the second generation stents.
Well, kind of third, because these are all your Orsiro, these are like 5 and 6, or Synergy Megatron. You know what is doing now here, particularly the left main ostium, and so Synergy Megatron, which is basically, we always wanted extra strength, not available in India. Hopefully by end of this year, we'll have that.
Yeah.
Synergy, first we have to get Synergy XD, then Synergy Megatron, but Megatron is a special stent for this purpose. Only problem is, Megatron will make this turn.
Will
It will
not
be a
make
little,
the
may
turn.
not make this turn, although once you already a guideliner, your Godzilla will make it. But yes, osteal lesion, now we have a new stent available. I know Merrill has another one. Basically the key is that Megatron is especially for this purpose, that take care of the osteal inelastic lesions. Yeah.
Right. So, yeah, Samin and Dr. Kinney, that was a wonderful demonstration of a very difficult subset of a patient with calcific osteal
Everybody come this way.
lesion, a
Yeah.
tortuous vessel. So, very well done, and so many points to take home for all of us.
Beautiful.
So, thank you so much.
No, nothing. Yeah. Okay. Beautiful. I'll just join you. You start your discussion. I'll join you in few minutes.
Yeah.